Welcome, and once again, everyone. It's a pleasure to be here. We're going to talk about primary prevention ICDs in the context of myocardial infarction and heart failure, and in particular, the PROFID EHRA randomized controlled trial. My name's Chris Gale. I'm from the UK. I'm delighted to be joined by two key experts here, Nikos Stavros from Berlin and Valentina Kitifa from Rochester. Welcome, and it's great. We're going to start a discussion now about primary prevention ICDs in the context of heart failure and post-myocardial infarction, in particular the randomized controlled trial that I know you're heavily involved with, the PROFID trial. So Valentina, tell me, what's the evidence for primary prevention ICDs in patients who have had a heart attack, who have ischemic heart disease?
Yes, thanks, Chris. So we have very strong evidence from three large randomized clinical trials that established the benefit of ICD implantation in patients with a previous myocardial infarction and low ejection fraction. These included the MEDIT-2 trial, which was conducted from Rochester, showing a significant survival benefit from the implantation of an ICD in these patients. And similar findings were confirmed in DEFINITE and SCOT-HEFT.
And those trials were based in a population of people with heart failure and ischemic heart disease, or broader?
Yes, so actually the MEDIT-2 study enrolled only patients with a prior myocardial infarction and a low ejection fraction. And then DEFINITE-2, SCOT-HEFT included both ischemic and non-ischemic cardiomyopathy patients with a low ejection fraction and heart failure.
They were conducted some time ago, weren't they?
Yes, the challenge that all of these large randomized clinical trials were conducted in the early 2000s. Actually, MEDIT-2 was published in 2002, more than 20 years ago.
Yeah. And things have changed. Those trials influence us in the guidelines. And Nikos, what do the guidelines say at the moment about primary prevention ICDs in the context of ischemic heart disease?
Yes, thanks, Chris. The guidelines recommend, based on these trials with a class 1 recommendation and level of evidence A, the prophylactic implantation of an ICD for primary prevention of sudden cardiac death. But as you say, many things have changed since then. And it was interesting to follow the development of the 2022 guidelines for the prevention of sudden cardiac death, and the paucity of evidence, of new evidence, reflecting the changes that have taken place.
So it sounds like these trials conducted some time ago, very influential, very important trials, but things have changed. What has changed? We're aware that in this era, many cardiovascular trials have been neutral, and that's because of the mortality rates are falling, and it's very hard to get those recruit those mortality rates for the power of trials. But what's been happening in the sudden cardiac death event rate era at the moment? So in your trials, the event rates were really quite high, weren't they?
Yes, in fact, even when we just looked at the series of the MEDIT trials, we saw very clearly that the risk of all-cause mortality and the risk of sudden cardiac death declined over time. And when you look at studies with more advanced medical therapy, including ARNIs and SGLT2, these rates are even lower. In fact, there's studies suggesting today that only about 1% of the patients will ever have an ICD shock, so will ever have a true benefit from the device. So it's a real challenge.
Absolutely. So Nikos, yeah.
Yeah, we have several trials. We have all this new medication that has come out. So first of all, the coverage with beta blockers were not that high back then. We have new mineralocorticoid receptor antagonists. We have the ARNIs, and now we have the SGLT2. And it's impressive to see that for all these drug classes, we do not have only an effect on total mortality, but also specifically on sudden cardiac death. So it's a bit paradoxical that the cardiology community always presents very proudly all these results and saying these drugs target severe arrhythmias and sudden cardiac death, but we still stick to the evidence that has been back then. And also, as Valentina said, in parallel to that, we see that there is a decline in the rate of appropriate ICD therapies, which coincides, of course.
Absolutely. So, and this is in the context of people who have had heart attacks and who develop heart failure. So it's like we've got really good pharmacotherapies that improve prognosis and reduce these cardiovascular endpoints. Primary prevention ICD. So ICDs are actually beneficial, aren't they? They do what they're meant to do, but there are risks with them as well, aren't there? So should we talk about the risks of primary prevention ICD or ICDs? What are the problems with them?
Absolutely. With ICD therapy, we tend many times to forget that this is an interventional treatment. It saves lives, but at the same time, it has, as every interventional treatment, has some complications. And these are all different kinds of complications, and including some that are really relevant. For instance, infections or device endocarditis that are difficult to treat. And it is interesting to see that on the one hand, the rates of sudden cardiac death are going down, and this is well documented. There are many, many publications on that, analyzing the sudden cardiac death rates of the trials, of the large heart failure trials over the last 20 years, the sudden cardiac death rate going down, but not really considering that the risk of the ICD remains pretty much stable, and this is impressive to see. And looking at good registries, it's not negligible. So it's around something like, in the long term, something like 8 to 10%. So it is negligible, the risk of the ICD. So it's a benefit-risk ratio that we are talking about. We are looking at the benefit. It's not a no-cost therapy.
So there seems to be this tension in this group of people who have survived a heart attack, who go on to have heart failure with a severe LV dysfunction. And the tension is between pharmacotherapies that are really quite effective, ICDs that are also effective but have potentially got a risk. And it's that balance of when do we need to actually implant a primary prevention ICD. So what is the evidence? Is there evidence? How can we do precision medicine to identify who actually will need one and use an ICD, rather than the sort of wider blunderbuss approach, which is at 40 days, an ICD if you're high risk?
Yeah, so I think that's the real challenge, is that we do not have current data on this patient population. And to answer that question, I believe the only way is to do a prospective randomized clinical trial to look at this population today and assess whether they would benefit from the ICD or they would do just fine without an ICD implantation.
Absolutely, which very nicely brings us on, Nikos, to, so what do we need to do and what are you doing, Nikos?
Yes, what we are all together doing, and but may I make a short comment to the previous question, because this is also what we exactly looked at in the PROFID project. When we started, we tried to identify risk predictors to see who is going to benefit from the ICD. And we analyzed, as you both know, something like 200,000 patients from very different sources, from well-conducted registries, from randomized trial data sets, from national registries, from institutional research databases. Good databases, good quality databases, adjudicated endpoints, and we did not find any predictor. The only one was left ventricular ejection fraction, but also there, the predictive role was modest. And that's why we decided to go to the PROFID EHRA trial as it is conducted now, which is a randomized comparison of optimal medical treatment, contemporary optimal medical treatment, as it should be nowadays, plus ICD therapy, versus optimal treatment without ICD therapy.
Absolutely, and it's been described as probably one of the boldest trials in cardiovascular medicine for many, many years. But let's dive into that a little bit deeper then. So what are the inclusion criteria? Who are the patients that we're testing essentially or randomizing in this trial?
It's post-myocardial infarction, but pretty much the patients that we implant nowadays for primary prevention. Huh? So these are myocardial infarction patients who have survived a myocardial infarction that lies at least 3 months before, are on optimal medical treatment at least for 3 months as recommended.
And the optimal medical therapy there is the heart failure therapy and post-myocardial infarction therapies as well.
Absolutely. Heart failure therapy as recommended by the guidelines for heart failure by the European Society of Cardiology, but also optimal treatment for coronary artery disease, because this has also changed significantly over the years. So patients on optimal medical treatment, at least for 3 months, ejection fraction below or equal 35%, New York Heart Association class 2 or 3. So exactly the population segment that nowadays would have an indication for primary prevention ICD. These patients are randomized, almost no exclusion criteria, so no secondary prevention, of course, but otherwise.
And a big international study, so reaching across many countries in Europe and many centres across there as well. And the end point as well is?
All-cause mortality.
With some secondary endpoints pre-specified as well. Yeah.
Yes, sudden cardiac death and quality of life, time to events, cost effectiveness, all the important aspects.
So what's the call to action here? What do we need to do? So it sounds like there's fantastic evidence, but historical. Things have changed with how we treat immediate myocardial infarction, heart failure, and therapies thereafter. And that has probably changed the context and the relative benefit of a primary prevention ICD, which is what we want to do. So what's the call to action? What do we need to do? And what do we need to call to action to our audience?
Well, we truly need randomized data, so I think this study will be incredibly important. And then, maybe 2 things I can mention quickly is there will be 2 sub-studies in PROFID EHRA. There will be a sub-study looking at cardiac MRI and data from cardiac MRI, how this could potentially help identifying patients at a higher risk for sudden cardiac death and VTs. And there's also a genomic sub-study, again, looking at potential genetic markers in this population as well. And I don't know if, Nikos, you wanted to mention additional details on that, as this might be crucial as well.
Thanks, Valentina, for bringing this point, because this brings us again to the hope of personalized treatment. So we have not abandoned the hope, so we thought, what are the 3 most promising factors? So it's MRI. It did not show a sign in the retrospective analysis, but you do not know whether this remains so if you conduct AI-led analysis of the raw images. So this will be analyzed in the CMR sub-study and the genomics. And additionally, as you know, we are conducting an AI-based analysis of the ECG. So it's the first time that all these 3 potentially helpful risk markers are examined in a prospective way. So this is exciting. We need to see whether they bring any benefit.
And these are pre-specified sub-analyses, aren't they? So it sounds like we're tackling an unmet need here. And you mentioned the precision medicine, which I think is great, but I think we're doing even better than that, because I think we're doing precision-based population medicine, because myocardial infarction is desperately common, heart failure is desperately common, and we're going to do some precise personalization of that medicine as well. So I think it's a fantastic trial, and I'm hoping everyone's going to join us and identify centres and patients for that. But I'm going to wrap up here and say thanks to Valentina for joining us, and thanks to Nikos. This is a great study, and it's a pleasure to be part of that. And let's do some good science and push medicine forward. Thank you very much for joining us, and we'll see you next time.